Introduce Dr. Kendra Klein. She's with ophthalmology at Lahey Health. I'm not sure what state that's in, Dr. Klein, but we so appreciate you stepping up and presenting to our families today. It's much appreciated. Where is your facility located?
So we're actually north of Boston in Burlington, Massachusetts. But yeah, I'd like to say thank you for having me. It's nice to meet all of you. This is just such a wonderful forum and so exciting to see everyone's faces. I also want to say thank you to Dr. Bakal, who's at Associated Retinal Consultants. So a little bit about myself. I born and raised in upstate New York, and I did my medical training, my residency and fellowship at Tufts New England Eye Center, which is in Boston. And then I joined Dr. Bakal at Associated Retinal Consultants in Phoenix for about 4 years, worked in private practice, found out I was pregnant with my second baby 12 months after having my first daughter during the height of the pandemic, and decided to move back to the Northeast to be closer to family. And so I joined the folks at Beth Israel Lahey Health. It's a health system surrounding Boston. And I spend a lot of time actually educating trainees. So I teach the Tufts medical students, and I'm the co-program director for the ophthalmology residency program at Tufts. And we have our own surgical retina fellows as well that we train. So very involved with that and with education. So I actually found out I was a carrier for Cohen syndrome when I was pregnant with my first child. And I was doing research on it actually at the time with Dr. Bakal in Phoenix. And so the OBGYN said to me, like, oh, you're a carrier for these things, and this thing, I don't even know what it is. And I said, well, I can take a moment to educate you on this because I'm actually doing research on it. And so I always do a presentation for my residents and fellows about Cohen syndrome and other inherited retinal diseases that are less well known. And if we have time at the end of the presentation, I can show you our slides from our American Academy of Ophthalmology meeting last year, where Dr. Bakal and I presented a paper about Cohen syndrome. So something we're working on.
Awesome.
Yeah, but I am not a geneticist. I am a medical retina specialist. So everything is very clinically based. And so my slides may seem a little bit basic as far as the gene therapy and things like that, but I'll just give you my my retinal perspective, kind of what we're doing clinically.
Now that would be great, because this is families on here, and sometimes if it's too sciencey, it's almost over the top.
It's a lot for me too. So I always ask Dr. Bakal when it comes to things like that. So So let me see if I can share
share screens in the bottom, kind of in the middle. You should be able to go on there and share your screen.
So this is the one keynote. That's what I want. Okay, and then I want to make it big. Hold on.
I know. So that's the tricky part. Okay, I'm gonna go ahead and mute.
And then let me see where are those buttons that you said to advance? Can I use my?
Should be on the bottom. There should be some type of slide. At least on mine was. It was kind of on the bottom of my page, and I don't know that I can see it, but it was kind of like it had a little.
I can see my mouse right now. Hold on. Let me see if I exit the.
Yeah, because see how there's the play? See the play up towards the top? All right, then over to the left. Yep, to the left.
I'm sorry. It's
no, I see him. It's kind of like top, then move over to the left one more. And there's a play right there.
I see Q&A. No?
Oh, you don't see, I see a play. Yep, you're so close to it. It looks like it's
I don't have that. Wait.
right there. Your mouse is it's
really?
messing with you.
Oh, you know what? Oh, it's underneath. I'm sorry. Okay, let me do this.
That's okay. Now you should hopefully see it somewhere on the bottom, I believe, to advance the slide.
But I don't.
If it's like mine. That's all right. Take your time.
I just see my I just hit it. Okay. Okay, never mind.
I know it's kind of hidden. Okay.
This should work.
Perfect. Okay.
So, okay, yes, this is me, and these are all my affiliations here. Okay, so I'm going to briefly go over the Cohen syndrome features. Like Dr. Wong said, you guys all know about this more than I do. So I'm really going to dive into the retinal dystrophy findings specifically. in Cohen syndrome, and then go a little bit into what we do in the clinics to diagnose this, how we approach patients that come to us with generalized kind of eye symptoms, and a little bit into the treatment options and the research frontiers for Cohen syndrome. So we have all heard that this was a new syndrome described in 1973. Well, it was first coined that by Cohen et al. And in that paper, they described characteristic facial features, hypotonia, developmental delay, hyperextensible joints, and variable ocular findings. Over the subsequent years, over 100 more cases were published in the ophthalmology literature, and clinical features of Cohen syndrome were more extensively described, including neutropenia. And currently, these numbers kind of change all the time, but the estimated incidence is less than 1,000 cases worldwide and over 200 cases reported in the literature. But as we know, this is probably underreported and underdiagnosed. So it is important, you know, at least from my perspective as an educator, to just get these, get my, you know, students kind of thinking about these different things and trying to find patterns when someone presents in the clinic. And although there is heterogeneity or a lot of differences within the same syndrome, there are certain cardinal features that emerge, which we have already, you know, gone over. But from an eye standpoint, it's really the retinal dystrophy finding and the high myopia, which means nearsightedness, which is almost universal. Microcephaly, developmental delay, joint hypermobility, etc. My favorite descriptor, which is overly social behavior, which I love and is close to my heart, and neutropenia. So in 2003, a team of Finnish scientists identified the gene for Cohen syndrome. It's located on chromosome 8. It was initially referred to as CO1 and later renamed VPS13B, which stands for vacuolar protein sorting associated protein, which basically means it's kind of the Uber. It transports and sorts within a cell. And so this gene is important for various developmental properties in ocular, hematologic, and CNS systems. And there have been over 200 identified disease-causing variants. And we're learning more, just like Dr. Wong said, with these variants of unknown significance. Over time, those may be reclassified variants into pathogenic. And he very well went over the autosomal recessive inheritance. So this is not a completely exhaustive list, but you can see that Cohen syndrome affects many different systems in the body. And you're aware of those things, but specifically, I'm going to talk about my favorite system, which is the eye. So as a little schematic here of your eyeball and what happens. So light comes from, you know, the outside of into the clear dome-shaped area here called the cornea. And then the iris, which is the light colored part of the eye, forms the opening of that is the pupil. And so when you get dilating drops put in your eye, that's really opening that iris and enlarging the pupil to see the back of the eye. The lens is this part right in the middle here that condenses the light and refracts the light. And you have hopefully a clear focused image on your retina. And in this diagram, it's focusing light in your macula, which is the centermost part of the vision, and the centermost part of the macula is called the fovea. And that's kind of the part where your fine vision, your details come from. And then those electrical impulses are transmitted through the optic nerve and go to the brain, where the brain then interprets those impulses into images. There are various features of Cohen syndrome. They're not all listed here, but some of the more common ones are, it tends to be high myopia. So, you know, I ask people their prescriptions, like if you take your glasses off, can you see okay? Or can you not see anything? So these are more on the order of like, you know, -4 or -9.
I think we're getting a little bit of a lag. Hey, Dr. Klein. Oh, Oh, maybe, okay, maybe yeah, maybe, all right, so she'll pop on, okay. I think she just had an internet lag. Okay, I'm gonna unmute you. Yeah, you're still muted. Hold on. All right, bear with us.
Oh no, can you hear me now?
Yeah.
Not okay. It's the only time
Yeah.
I've been on all morning. This is the only time that my Wi-Fi is cut off, of course.
I know, I'm direct connected. It happened to me last conference.
Sorry.
I fell off at the tail end, so no worries.
Can you see my screen again, or do I have to do
No,
this?
I think you have to restart. I
Okay.
think you popped out and popped. Yeah,
Oh my God, I'm sorry. Let me see.
that's okay. It happens.
Share
That's
screen. Let me go to this one. I think I'm getting faster at this.
you're back in.
Okay. So myopia, very nearsighted, progressive and early onset, astigmatism.
You're cutting in and out again. It seems like when you turn your presentation on, you start to cut out.
In, out, up, down, and it's all named different things. You can also have downward slanting eyelids or cataract, which is a cloudy lens. And I put a picture here of a sublux lens, which is a dislocated lens. So there's little kind of fibrils that hold the lens in place. And in Cohen syndrome, those can be very lax. And so you can have dislocation of your lens easier than normal. And you can get eyelid drooping as well, which is called ptosis. So in terms of the retinal dystrophy, one of the most common complaints is decreased night vision, which we call nyctalopia. And that can occur as early as the first decade of life, and also constricted peripheral vision, which tends to be progressive, and that can appear in the second decade of life. On exam, you can see a pigmentary retinopathy, and I'll show you kind of example of that. It's good to know that many do have useful vision preserved until the fourth decade, although it can be significantly impaired, and the peripheral vision may be significantly impaired, but total blindness, what we call no light perception, is uncommon. And these are just little representations of nyctalopia and visual field constriction. So in our retina clinics, what we do is we look at structural findings and functional testing, and then finally the genetic testing component to it in order to clinically diagnose someone with an inherited retinal disease like Cohen syndrome. So we do a dilated eye exam on everyone. That's where we put the eye drops in and your pupils get really big and you need to wear sunglasses after. We take different retinal imaging photos. We have wide field fundus photos where you can actually get pretty nice pictures, even undilated, and something called an optical coherence tomography, which is an OCT scan, which is really integral to us in retina clinic for basically every retinal issue. But I'll go through some findings on that as well. And then the functional component of it. So even structurally, if everything looks okay, that doesn't necessarily mean that the cells are functioning properly. And so we look at visual field testing and something called an ERG or electroretinogram to tell us about the function of the eye. And so as a little overview, you guys may remember or not the retina, but I look at this every day. So I don't know, I don't have a pointer or anything, but in that diagram up on the top, you can see there's a retinal vein, there's a retinal artery. So just like elsewhere in the body, we have arteries bring blood to the eye, veins that drain the blood from the eye. The optic disc is that kind of bundle of neural tissue that connects your eyeball to your brain. And then you have the macula, which is the area in between those vessels there. And right in the center is the fovea. That's that kind of dark brown spot that's devoid of vasculature, where all of the really detailed vision comes from. And on the diagram to the right, you can just see light waves entering the eye. They go all the way to the back to the rods and cones, which are the light sensitive cells of the eye. And then they move back upwards through the retina and exit through the optic nerve there. And then it goes to the brain, where you get these electrical signals that turn into the images that you see in the occipital cortex, which is in the back of the head. So this is Dr. Bakal's eye. So that's the retinal, what we call the retinal periphery. I just want to get everyone on the same page because I'm going to be using some terminology here to describe the pictures that are coming. So look at the normal first. There's the macula, our fovea, and our optic nerve. That's what it looks healthy wise. This is a 28-year-old male with Cohen syndrome. You can see that the optic nerve, it's hard to tell in this picture, but can sometimes look a little pale or a little bit whiter than normal. The vasculature, those retinal vessels are skinnier. They're what we call attenuated. And most, prominently, you can see these pigment clumps in the retinal periphery, and that's what we call bone spicule hyperpigmentation. It's not specific to Cohen syndrome. You can see it in other retinal degenerations like retinitis pigmentosa, but it just means that there's unhealthy retina and retinal pigment epithelium, which is the kind of pigmented layer under the retina in those areas. So a little clue there. This is a 15-year-old female with Cohen syndrome. Actually looks pretty normal. The retinal periphery may have some loss of pigmentation there, but I put this up because you can definitely see a wide variety of structural findings. So that's why it's important to kind of get the whole picture and do all of the testing. So this is the OCT test. And so this is cross-sectional retinal imaging. It's very quick and painless. You get a really nice visualization of the retinal layers. And what it's doing is it's measuring light reflectance off the retina. And so different tissues reflect light in a different way. And so you get this really nice, cross-section analysis of the retina, which shows you the different cellular layers of the retina. So that's a normal retina. Some people call it an optical biopsy because you can really see the different cellular layers. And something that I focus on when I'm looking at a patient that potentially has an inherited retinal degeneration are those two highlighted layers. And the red represents the photoreceptors, the rods and cones, and the green, the RPE, which is the retinal pigment epithelial layer underneath it, because those layers are affected. On the left, you can see the normal retinal diagram, and on the right, you can see a patient with Cohen syndrome, and one of the arrows is pointing to the photoreceptor loss. So you, where you'd normally have those bright outer reflective bands, you're missing a band there. So that's telling you, okay, the light sensitive cells aren't so healthy. And then you see these black hyporeflective spaces within the retina itself. And that's something called cystoid macular edema. And cystoid macular edema, or CME, occurs in a variety of retinal dystrophies, including retinitis pigmentosa, X-linked retinoschisis, and Cohen syndrome. And in contrast to people with age-related macular degeneration or diabetic retinopathy, these cysts are believed not to be from fluid or exudation, but more from loss of tissue or disruption of the normal retinal architecture. And sometimes we prescribe eye drops to help pump that fluid out, and that can be effective. So I want to go into the functional testing component of it now, because these are all common things that patients go through when they're trying to get a diagnosis. The visual field testing is measuring the field of vision via sensitivity to various bright and dim lights. So again, it helps determine the level of functional vision, but also can monitor progression of the disease and helps us correlate the structural and functional changes. And this is just a picture of someone who's going to have a visual field test. It's kind of a boring test, but you put your chin in that little chin rest, and he's got this little kind of buzzard looking thing, and you click that whenever you see lights coming in. And commonly in degeneration patients, we'll do kinetic visual fields, which just means the light is actually moving and it kind of comes in from the side. And as soon as the patient can sense the light, they push the button. And what that does is it maps out your field of vision. You test one eye at a time because there's some overlap in our field of vision, but you end up with this map of what you can and cannot see. So this is an example of like a readout we would get. And on your left, it's a normal field. So someone with no eye disease can see, these various lights, and each colored ring here corresponds to a moving light of a certain size and intensity. And so the smallest ring, that purple ring, is the smallest and dimmest light. So, you can't really see that until it's really close to the center of the vision. The blind spot is that kind of circle right there, and with those little triangles, and that corresponds to where your optic nerve exits the eye, and we all have that. But if you look on the right, you can see the constricted vision, someone that would have more advanced visual field loss. And so even the brightest lights, can only be seen, centrally. And I always, tell my students this, is that it can be deceiving. Someone can read an eye chart, so their visual acuity could be very good. So maybe they read the 20/20 line and you're like, oh, okay, they're doing pretty good. They must not be that affected. But then you get a visual field like this and you're like, okay, their functional vision is not very good because they cannot see, they can just see straight ahead. So, going downstairs and seeing in dim light, people really have a hard time. An electroretinogram, or ERG, is another measure of functional vision. And this is measuring the electrical response of the retina to a light stimulus. So everyone's very familiar with EKGs. It is kind of, to me, like the EKG of the eye. It's looking at the mass response or function of the retina. It can't tell you specifically about pathology in certain places of the retina. It tells you how overall the general health of the retina. And so by varying the light stimulus that's applied to the eye and varying the testing conditions, so you can dark adapt, meaning you keep someone in the dark for a while, and then you do the test. You can look at either the rods, which are the cells responsible for dim light vision and your peripheral vision, versus the cones, which is more active, the cells more active in bright light and responsible for your central vision, your fine visual details. It's painless, test. There's various electrodes, but we use a DTL electrode, which is like
you're lagging again, Dr. Klein. Go ahead and bear with us. I think her internet's lagging again. I think she's on a Wi-Fi network, so I'm sure she'll get back on. Hey, it happens. Don't worry about it. I think we just need to get you to unmute. Let's see.
Oh, can you hear me?
Yeah.
Okay, I
can hear you
changed
now.
my Wi-Fi. I'm sorry. I'm like at my in-laws farm in Connecticut right now. So I'm gonna go onto my phone wireless, and I hope that this is
Okay. Yeah, sometimes the Wi-Fi signals can be really difficult.
yeah. I'm sorry. Let me
That's
do
okay.
this again. Now I'm gonna be a pro at this. Let's see. Okay, is this where we left off?
So,
My
is it
ERG. Can you see?
I was gonna say tape off the video while you share. Oh, someone's saying, Valerie saying, if you turn off your video while you share, it might reduce how much bandwidth you're using. What was the slide before?
I was at this one.
Okay, that's where you went out. You run.
So if I do that, stop my video, you can still hear me.
Stop.
Okay.
Yeah.
So
do
let
that.
me do your screen.
Thanks, Valerie.
Thank you for that tip. Okay. Let me do play. Okay, so this is just the ERG readout. So what I was saying is that the top would show you the normal and the bottom would show you an end stage retinal dystrophy where the responses are extinguished. But you can use the ERG prior to this when people still have, electrical responses to measure the functional change over time. And this is just, you can separate actually your rods versus your cones, which is helpful information for us. So finally, there's genetic testing, which is done oftentimes in our offices. We can take a little saliva sample and send it off to the lab. There's variable insurance coverages, but I just added to this presentation, actually, looking at the questions that people had, some sponsored genetic testing programs that are out there right now for retinal diseases. And so I'll go through that. But the result of genetic testing is important because it tells you a molecular diagnosis, which can help with the prognosis and the inheritance pattern, but also determine eligibility for future gene therapy trials. So current management is, prescribing glasses for refractive error, going over low vision tools and training, physical speech therapy, and of course, it's a multidisciplinary team to take care of these patients. I'm going to briefly go over some research on future treatments. And again, I'm not a geneticist, so I'll do a very high overview of this. So, what's a gene? We went through this, a section of a DNA strand that codes for a protein, which are the building blocks in the body. Chromosomes are coiled up DNA strands inside of cells. And how many genes are associated with inherited retinal degeneration? Does anyone want to guess?
I have no idea, but we have everyone muted.
Oh yeah, greater than 270. And it may be more than that by now. This was just the last one that I can find. So gene therapy. So you can, when you're talking about gene therapy, you can either talk about gene supplementation, which is what or replacement, which is what I think of when I think of gene therapy, but there's also silencing of mutant genes. So gene supplementation, though, in the IRD space, refers to restoring the defective or missing gene by introducing a functional copy into the cells. And these are for what we call loss of function mutations. And when we talked about vectors, we're just talking about the delivery mode. So how do you get this information into the cell? And typically we're talking about viral vectors. And in retinal diseases, the adeno-associated viruses are often used for retina because of their low immunogenicity or their low toxicity and their ease of manipulation in the lab. But it does have limited cargo capacity. So some of these larger genes may be better suited for these larger vectors like lentiviruses. So techniques for vector delivery. So you could do it intravitreally, which looks horrifying to see that big needle into the eye, but actually it's painless. We numb up the eye with lidocaine, and you put a little bit, of medicine into that space in the back of the eye, which is called the vitreous cavity. More commonly, though, for gene delivery, you're talking subretinal. So you would go into the operating room and you would have a vitrectomy done, so clear out some of that vitreous gel, and then actually put a needle under the retina. So you kind of make a retinal detachment on purpose and place the material right underneath the retina, between the retina and the RPE. And so there are many retina gene therapy trials. And so that again kind of reflects why it's important to have the genetic testing be done. One I'm just going to briefly touch upon is the AAV RPE65 gene therapy. So the first FDA approved gene therapy is for a retinal disease. So very exciting. It's for Leber congenital amaurosis, which is a form of infantile RP. And there are over 25 genes associated with LCA, including the RPE65. The first phase 3 randomized gene therapy trial for any genetic eye disease was completed in 2015, and their primary endpoint was met, which is passing an obstacle course at a dimmer light. So this is not seeing the eye chart better. This is functional improvement. So these patients could actually function better. And so the FDA approved Luxturna in 2017 for children and adults with RPE 65 associated RP. Dr. Bacall has several patients that have been treated with this. And they will report that they can see stars in the sky, and they've never been able to see that before. And there are multiple other gene therapy trials in retina diseases that are ongoing. So I just added this while we were talking before I came on. There are some sponsored genetic testing panel programs for IRDs, so for in the retinal disease space, and these include the VPS13B gene. So the Foundation for Fighting Blindness, my Retina Tracker Registry, and the I Want to Know through Spark Therapeutics are two sponsored programs. And I just put the links here so you could read more about it. And then there's the Invitae Genetics ID or IRD. I've used both of these sponsored panels, and they're great. They have genetic counselors if a patient doesn't have a genetic counselor. So sometimes patients do present to the retina specialist, and we always have them see a clinical geneticist. But just if you're trying to get something, a gene, and to qualify for a clinical trial or just for the knowledge, there are some sponsored programs out there. So I'm not going to go into this, but cell therapies, people always ask about cell therapies. There's usually we're talking about cell replacement, and in retina, that's usually the RPE or the photoreceptors, those light sensitive cells. And there are different sources. So you have pluripotent stem cells, which are cells that can differentiate into all of the different cell types. And those are embryonic derived or reprogrammed adult cells. And then multipotent stem cells, which differentiate into many, but not all cell types. And those are non-embryonic or perinatal cells. Other therapies, gene editing. So that's altering a patient's own gene, rather delivering a functional copy of the gene. So you might have heard of CRISPR. Those are what I think of as molecular scissors that edit DNA sequences. So they target the sequence, they go in and they clip it and they put in a new, this is probably not at all how it works, but this is how I think of it. Go in, clip out the bad one, put in the new one. And that's technology that's still evolving, and optogenetics, which is more suited for late stage disease or for undetermined mutations. And that's genetically introducing light sensitive proteins, trying to confer sensitivity to light. And both of these currently have their limitations. So in summary, Cohen syndrome is associated with a variety of ophthalmic conditions. The retinal dystrophy typically presents with decreased night vision and restricted peripheral vision. Monitoring, genetic testing, low vision tools are recommended, and future treatment options are really looking at gene therapy. Thank you. And thank you to Dr. Bacall. If we have time, I can show you, are people interested in seeing our data from AAO?
Yes, we have plenty of time, Dr. Klein. So if you would like to do that, that would be great.
Yeah, so this is just data that we presented at the American Academy of Ophthalmology last year, which is like ophthalmology's main annual meeting. And so these were structural and functional retinal findings in Cohen syndrome. And I believe we have more patients that we're adding to this study as well, but this was just highlighting ophthalmic and genetic features of 11 patients with molecularly confirmed Cohen syndrome. And so these 11 patients were aged from 2 to 28 years, and they underwent ophthalmic assessment. This was in our Phoenix practice. And there were 2 sibling cohorts, and the remaining 6 were unrelated. And the most common systemic morbidity was developmental delay, followed by neutropenia and hypotonia. Am I on? Okay. Can you hear me? This just.
Yes. Sorry,
okay.
I was on
Sorry.
mute. Yep.
Something.
No,
Okay. Something. Okay. Sorry. Now I'm paranoid. Okay. That I'm talking to no one. Okay. So the most common systemic comorbidity was developmental delay, followed by neutropenia. And you can just see in this chart here. And unique coexisting diagnoses included juvenile idiopathic arthritis, pica behavior, which is eating non-nutritive substances, iron deficiency, anemia, and oral ulcers. So there were some unique features identified. And the presenting symptoms, most people presented with blurred vision was the most common thing that they said, followed by visual field loss or constricted vision and night blindness problems. Refractive error, so that high myopia and strabismus or eye crossing were the most common ocular comorbidities. All of the patients that were able to participate in Snellen testing, that's the eye chart, reading the letters off, had reduced best corrected visual acuity. And one patient had a cataract. Pigment modeling, those kind of pigment clumps that I showed you before, and the attenuated vasculature were the most common findings in the back of the eye, followed by bone spicules, so those kind of dense pigmentary changes. Visually evoked potential, that's another way of measuring kind of the visual function in the eye. And all of the patients that had ERGs, that's the electrical testing, were abnormal, and 5 were extinguished. And so the 2 patients able to participate in the visual field testing showed severe constriction. And so basically what that's telling us is that even the patients with mild changes on exams, you look at them, if you're just doing a regular eye exam and you're looking, you say, oh, there's nothing wrong, it looks fine. They still have loss of functional vision. So you really have to get these other, you have to be aware. I always say to my students, just listen to what the parents tell you. Like they will tell you, the problem. You have to do this other testing to kind of get the full picture. So all of the patients demonstrated mutations in the VPS13B gene. One family consisting of 4 patients demonstrated 2 heterozygous variants, one being a pathogenic or known pathogenic variant, and the other being a novel variant. So one of those variant of VUS, unspecified significance. These are just some pictures, so you can see the typical findings of a later stage retinal dystrophy, where you have that pigment modeling in the periphery. C and D show you fundus autofluorescence, and that shows you the health of the RPE, or that pigmented layer under the retina. And so sometimes that can show you more extensive findings that you would see on clinical exam alone. And then in the bottom pictures, you can see those OCT scans where this patient has cystoid macular edema, or those hyporeflective spaces. Now you guys all know how to read an ERG and a visual field. So you can see that the ERGs are in patient 3 are pretty much extinguished. There's no recordable waveforms there. And the visual field's constricted to less than 20 degrees. And so that alone is a criteria for legal blindness. This is patient 4. You could see that they have very mild changes in their retina, but their ERG is unrecordable. So even though their pictures, like to the ophthalmologist, might look, pretty normal, they do not have functional vision. And this is just the sibling of patient 4, which also shows mild pigment modeling. And you can see in these OCTs, it's hard to see in this picture, but there's loss of those light sensitive cells. So in summary, we just kind of went over the systemic and ophthalmic features of patients presenting to our practice. The posterior segment abnormalities were varied, but the bone spicules, optic nerve pallor, and the hyperpigmentation were the most common, and this aligned with the original report of Cohen syndrome. And of the patients who underwent functional testing, all of them demonstrated global retinal dysfunction, with even the youngest patients, like 2 years old, having moderate ERG attenuation, despite having minimal changes on exam. And so in conclusion, report was just done because the retinal findings are distinctive and can help aid in diagnosing these patients. And if you see, and I always tell my students, like, look for overlapping characteristics, and that should kind of send a light bulb off. Like, we should, do further investigations. And now, especially in this age of genetic testing and with these inherited retinal panels, we can very easily do genetic testing at low cost or no cost to the patient in the clinic. And so, as more of these cases continue to be reported, we're going to know more, and this will make the development of future gene therapy trials more attainable. Thank you guys for your attention and for bearing with me as my internet kept cutting out. I'm really sorry.
Oh, hey, that's okay. Hey, Dr. Klein, can you see the questions or can I read them to you? Because I know, and we have plenty of time. I know the
Yeah.
eyes. Yeah. Can you actually see the questions on the Q&A?
Q&A. Yeah, let me pull it up. Okay.
Yeah, looks like
Hi,
we can
Dr.
do.
Klein. My son has been using brinzolamide. Would that be helpful with his eye pressure? Yes, brinzolamide is it's a carbonic anhydrase inhibitor. So it's like dorzolamide, the one I put in the example. So that can help with cystoid macular edema, but it also does lower your eye pressure. Hi, Dr. Klein. Our son, who is 6, was sent for eye ultrasound as there's little white fluffs and clouds. Okay, let me see. We went to a retina specialist who could not tell us exactly what it is, but she lasered them. When we came back up for a follow-up, they were gone. More appeared. She lasered them again. Ultrasound. Yeah, I'm not sure if this was, there's a couple. So on ultrasound, you basically are just getting major anatomical things on an ultrasound. I don't know if the white fluffs or clouds that you're referring to are vitreous floaters. So you can sometimes get floaters in the back of your eye, which you can laser, although I don't necessarily recommend doing that. I don't know, 6, I'm not sure what would happen. I mean, you'd have to get me more details on that. I'm not sure exactly what they would be lasering. Because if sometimes you can get cataracts, but you wouldn't laser a cataract. So it might be floaters. Okay. Am I familiar with the nanoscope trial? I am not. I'll have to look that up and learn more about that. Let's see. Scleral buckle with laser was a potential option to do prophylactically. Is this something anyone in our community has had? So, it's scleral buckle with laser. It's definitely been done, and I'm not a retinal surgeon, so I don't do that procedure. But in some patients with high myopia or very, very nearsightedness, their retina gets very thin at the edges is the best way to describe it. And sometimes, and there can be lots of tears or you can get lots of thinning. So sometimes they will do a scleral buckle, which is basically like an eye band. Here, let me put my video on because I'm Italian and I use my hands. There's like a band that goes around the eye, and they can do laser 360 degrees. And that could be a prophylactic way to keep the retina attached. And in Cohen's syndrome specifically, I don't know of any data either way, but there may be some data in the Stickler syndrome report. So Stickler syndrome is another genetic condition, and patients are very prone to developing retinal detachments. So I would probably look at the Stickler syndrome literature with that. And yes, to Anna, I can share the presentation with the medical team. Just tell me where to send it.
Yeah, we'll have recordings too.
Yeah.
So the Zoom is being recorded. So I think what we'll do is we'll have portions of it recorded.
Yeah. And I'm sorry about the daughter that had a retinal detachment and lost vision in the right eye. I would say that retinal detachments happen more frequently in patients that have high myopia. So that's the main risk factor for that. And there may be other mechanisms as well that we don't understand. We know there's a higher degree of, subluxation of the lens. So there may be some laxity that may predispose to retinal detachments as well. I think that's why it's so important to make sure that you see I would say a retina specialist in particular, if your son or daughter has Cohen syndrome. My daughter's been given Diamox for cysts in the eye, did not reduce the cysts, and now we are just monitoring. Go back on the Diamox. I don't, the Diamox is, so the drops are, what I was saying, carbonic anhydrase inhibitors, and Diamox is the pill version of those drops. But it's a diuretic, so it can give you some electrolyte imbalances. So usually I don't keep people on Diamox chronically. I would probably just try doing either dorzolamide or one of those eye drops to see if that helps. And if not, you can monitor, because sometimes these cysts are not visually significant. And they're not, like I was saying, it's not really exudative or leakage. It's just degenerative cysts. All right, let's see. Got a lot of eye questions. This is good. Okay, let's see. Our son had low vision. We were told that the cataract he had came from RP, went to Johns Hopkins, cataracts removed, vision got worse, and no vision in either eye because the cataract in the other eye is so thick. They would like to take it out. Wondering if that is the best, they really, I would say, I defer to your ophthalmologist. It depends. I think that if the cataract is significant enough that it's blocking any light getting to the back of the eye, it's usually a good idea to have it removed by a pediatric ophthalmologist who specializes in anterior segment surgery. There's a lot to pediatric cataracts, so you wouldn't want a normal, adult who does, cataracts and people in their 60s to 80s doing the cataract surgery in a child. It's very different. But it's important to have these eye exams, get any kind of media opacities clarified. And that can even be just getting glasses, because we worry about something called amblyopia. And amblyopia is a problem where it's a developmental problem from your eyeball to your brain. So it's the optical pathways that don't develop if you don't get the light and get the visual processing information in the eye. So I would defer to them, but if they are recommending removing the cataract, then that's definitely something to consider. But you want to make sure that you have a pediatric, cataract doctor, basically. Okay. Oh, thank you for removing those other way at ones. So have also recently tested positive to a mutation related to Leber hereditary optic neuropathy. Leber hereditary optic neuropathy is a different mutation. It usually can affect males, and they can have sequential vision loss in their right eye than their left eye. So I would say that a neuro-ophthalmologist would be the best person to see regarding that issue. And again, neuro-ophthalmologists, there's not many of them. There's more retina doctors than neuro-ophthalmologists, but neuro-ophthalmologists are really they would be the best person to see for that specific thing. So you might want to see a retina doctor and a neuro-ophthalmologist, unfortunately, but they may have more information on like clinical trials or supplements for that.
I have a question, and I can't ask in the, I can't, because I'm a host, I can't ask in the Q&A. And I sent you a chat. I don't know if you're seeing the chats as well. But my question,
not. Okay.
my question was, based on experience, it's very hard for our kids to get an eye exam at the doctor office. And every time they do it, my daughter's 27 now, it's always like, how do you know? How do you know what's going on in there? And they're like, well, we put the light and we flash it and we can kind of see in the back, but we don't know 100%. So can you, other than putting them out for an ERG, I guess that's what they have to do. Can you suggest anything else that we can maybe tell the doctor to? I mean, obviously they're specialists in retinas, but is there anything that you can suggest to get the best quality exam for our kids?
Yeah. So one thing that actually I do, especially when I'm seeing young people or people that are just really light sensitive and can't really follow directions or something like that, is I do that wide field fundus photo. When I showed Dr. Bacall's eye, it's called an Optos fundus photo, but there are various wide field fundus imaging, and they're pretty much everywhere, access to them. Most of us have wide field imaging now. So sometimes we'll just do that, that you do the best you can, and you don't even need to be dilated for that. If you are dilated, it's easier because it's just a better picture, but that would really just consist of putting, your head in this little kind of chin rest and taking a picture of the eye, and it's very quick. And so sometimes I'll do that just to because it's a large step back, and you can see some of those changes. And when you do that, you can also do the autofluorescence, and that will show you the health of the RPE. And that's just takes a couple seconds to do. And a lot of children can do OCTs as well. You kind of tell them, oh, it's like a motorcycle. Just hold on here and put your head here and take pictures. It just takes a lot of patience. But a lot of those, I would say, if you're going to get, and in visual fields, you can't do in young children because it is, it requires them to push a button when they see a light. Many adults can't even, do a visual field test, without falling asleep or losing interest. But if you wanted to get a measure of functional vision, you could do an exam under anesthesia and do the ERG that way. But otherwise, and that's why when we do these studies, it's limited. You do the best you can do, but a lot of times that's just take a picture, wide field fundus photo, and get an OCT, and that can tell you
wide field, what photo?
Either an Optos photo or a wide field fundus imaging.
UNDIS.
And that should usually, do that.
Getting drops in them is half the battle too.
Yeah, and so you can do that undilated, which is really nice. It's called, the technical term is non-mydriatic imaging. Mydriasis is when you kind of dilate the eye. And so the technology is a lot better now than it used to be. We didn't have any of this technology probably even 10 years ago. So
thank you.
Yeah.
Yeah, and I think Dr. Klein, and I know my daughter Morgan, I
Yeah.
haven't done the ERG because she just won't, she would have to be anesthetized.
Right.
We even went to we went to Johns Hopkins and Eye Institute there, and that would be the only thing that we could do. And I guess it's interesting for you to say that, with her eyes, because Morgan's 21, and our Cohen kids have a super memory. I'm sure you heard that earlier. So I think my daughter memorizes everything. So
wow.
So visually, if an eye doctor is looking in her eye, what you're saying, without some of this deeper diving on testing, it could be her vision could be worse than we actually know.
Yes.
Okay.
It's just something to be aware of, that functional vision and, the cells, losing your rods and your ability to see in dim light, you have to be particularly careful about.
Oh yeah, and she's been night blind since age 7, so I know all about that. All right, I'm just trying to clear out for the chat here. I'm not sure which question you're on the Q&A. So
okay, so we are told that brinzolamide may have been what caused her high liver enzymes. Have you seen this? I have not. I find that so drops in general, eye drops, have low penetration into the systemic circulation. So one thing you can do, I have never seen brinzolamide causing high liver enzymes, but one thing you can do if you are giving someone eye drops and you want to decrease the systemic absorption is you basically just push right here and right near where your eye kind of connects to your nose. And that's where it drains. And so that just kind of keeps, if you give someone an eye drop and you just kind of push here a little bit, it just keeps that drop absorbing into the eye, and it's less absorption into the system. And it also is less of a tendency to go down the back of their throat and cause stinging and burning. I'm sorry that your daughter lost her eye after this. What happened with her retinal detachment? My daughter has just seen her ophthalmologist. She has myopia, -4 on her right and 3.7 on her left. She has gotten better on her left. I asked him if she's to start atropine. He said, no. What is your take in starting atropine sooner? So I think you're referring to, so there's some change in correction. And so when children are very young, they favor their better seeing eye, and they kind of ignore their other eye. And so those pathways don't develop as well. And so that's when you can run into amblyopia, which means if you don't correct that, and strengthen the poorly seeing eye, then those pathways never develop and you can never correct, to a certain acuity. Atropine is a way of kind of blurring out the better seeing eye to try to strengthen the other eye. It really depends on their visual acuity, and not the refractive error. So if their acuity is symmetric, then they won't need to keep patching or doing atropine. My daughter has foveoschisis, is not having any treatment. Her vision has deteriorated a lot in the last couple of years. So see a retina doctor. Foveoschisis, if they have a diagnosis of Cohen syndrome, you can see it in X-linked retinoschisis, which is a different thing, but you can also just see those cysts. So those cysts can sometimes look like schisis, but your retina doctor should be able to kind of help you out with that. And oftentimes foveoschisis is just seen in high myopia or being nearsighted, and we watch it. We don't usually do anything, and it may or may not progress, but usually we watch it. It's very hard. It's an anatomical issue that's very hard to correct surgically. Okay. Let's see. Is it common for a child to eventually develop resistance to durzolamide to a point it is no longer effective? Have you seen any success treating continued CME with an immunosuppressant like Cellcept or Humira? So people don't really develop a resistance to durzolamide in my knowledge, but sometimes it's not effective in treating the cystoid macular edema, and sometimes we'll just watch it. And it may not be visually significant. So sometimes I don't kind of chase that down anyway. So you wouldn't treat cystoid macular edema with immunosuppression, but you can see inflammation inside of the eye, which is also called uveitis, which can lead to a different type of cystoid macular edema. That type of cystoid macular edema is different than the one with Cohen syndrome, because if you do a dye test where you kind of inject some dye into a vein and take pictures, it's called a fluorescein angiography. There's actual leakage of fluid going on there. And so sometimes there's different ways of treating that type of CME. And it's not directly treated by immunosuppression. But if someone also has coexisting uveitis or inflammation inside of your eye, then sometimes we will treat with Humira or Cellcept. My daughter is 11 and her doctor just found traces of bone spicules in both eyes for the first time. She had her first ERG and we have had an appointment with a retina specialist. Is there anything else we can be doing to slow the progression of the RP? So if this is, it depends on what their genetic diagnosis is. Unfortunately, there's nothing really you can be doing to slow the progression that I know of right now, unless you're looking at different clinical trials. So depending on, the genetic defect, there may be some clinical trials. I always refer my patients to clinicaltrials.gov to kind of look at the clinical trials, but just monitoring right now, getting the genetic testing and treating things like amblyopia with glasses or patching. Do ERGs need to be repeated after time? My daughter had one last year at 2. Sometimes I do. An ERG, it's not that you have to repeat it. It's more that if you want information on their functional vision, sometimes we'll do it at diagnosis when we're trying to establish a diagnosis, because the different retinal degenerations present differently. You can have different ERG findings and you want to establish a baseline. So if you do repeat it down the road, you can see what the progression has been like in functional vision, but it's not something you absolutely have to do. But if you're curious about the functional vision or how it's progressed, you might want to repeat it in the future. Our son is 52 and diagnosed with Cohen syndrome at 27. Recently, we were told that he can now only see light in one eye. I noticed that there is now Luxturna for RP, which he has. Would this drug help at all, or is it a pill or needle in the eye? We live in Canada. So it's interesting because this is where terminology gets a little bit confusing. So first of all, that if someone has the Luxturna is only approved for retinitis pigmentosa caused by mutations, 2 mutations in the RPE65 gene. So if he has retinitis pigmentosa, which is RPE65 related, and it's molecularly confirmed, then potentially, yes, he would be a candidate for Luxturna. But sometimes people say that, you know, they refer to even Cohen syndrome as retinitis pigmentosa, but it's really nyctalopia and peripheral vision loss, which is secondary to Cohen syndrome, which is a different mutation than that. So it depends on the genetics, basically. Her ophthalmologist didn't recommend patches or tell us that she is favoring one eye more than the other. So this is probably the one about the atropine. We won't see him for another 6 months. Should I bring it up to him sooner? I always say, if you're concerned, bring it up to the ophthalmologist. And that's where you should go and get your answers. So if you have a concern, yes, just bring it up to your pediatric ophthalmologist.
Wow, great questions.
Yeah.
Dr. Klein, I wanted to ask you, because I've even used the term RP.
Mhm.
So, and there's quite a few of us in the group, and our kids all have, of course, like you said, there's 200 variants now.
Mhm.
How would, just because there can be crossovers of different things where there's something else in the family, what type of genetic testing specific would a family do for the eyes to figure out what it is?
Yeah. So what we do, and I've used Spark Therapeutics and Invitae, and when I was at Associated Retinal Consultants, we basically signed up our patients for my retina tracker that was on that slide that I had earlier, and then through them we would order these panels, and it was a sponsored test, and I think it's 250 or over 300 genes. And so they test for all of, basically, not all, but the vast majority of inherited retinal degenerations. And so you could see if your patient has, or if the patient has an RP-like syndrome, bone spicular hyperpigmentation, nyctalopia, visual field loss, that's kind of what we write down, and then we see, and a lot of times what we think is going on is not at all what's going on, and there can be a lot of crossover. And so that's why doing those genetic panels is really important, and it's very widely available. I have a bunch of kits, in my office, and I will just do like a swab, send it out. During COVID, we would send kits directly to patients' houses, and they would send them from their house. So if you have a retina specialist that's comfortable doing that and is versed in doing that, then that's the best way to do it.
Awesome. All right. Looks like does anyone else have any other questions? Because I think we answered everything in the Q&A box.
Oh, good.
And wow, Dr. Klein, you're amazing. I
thank
just
you.
want to say, I appreciate that you are explaining things in a very just toned down, something a parent can understand, which is a really great, I mean, it's very good, because we have families from all over the place. We're just parents. We're not necessarily sciencey, and it just makes it really helpful. I know the vision is a huge fear, or that's like the one thing with, the huge thing with Cohen syndrome, like that us as the association that we've always struggled with. And as far as reassuring and having some type of answer, and it is exciting with all the, with the vision studies that are coming out. So
yeah, this is I think in ophthalmology, it's a completely new world. And I think the fact that the first FDA approved gene therapy was for a retinal degeneration is so exciting. And even in our other, what I see in my day in, day out kind of bread and butter is like macular degeneration and diabetes. There's so many new treatments in ophthalmology and in retina that it's really, macular degeneration is a inherited condition that is very widespread, and we have a new treatment for dry macular. So they're just going to keep getting better and better. And so.
Awesome. Now, how many Cohen patients have you seen, Dr. Klein?
I've
Did you
just
say-
seen them. I've just seen Dr. Bacall's patients.
Yeah.
I haven't seen any in Boston. And again, a lot of that I think is, I think they're out there. I think some things are going underdiagnosed. But yeah, none yet in Boston.
I know we have
Right.
some people in New England, in the tri-state area. So
Mhm.
we have your information. Maybe we can direct them to you based on their
Yeah.
insurance.
Great.
Yeah.
And I just want to echo the thanks that Lisa gave, Dr. Klein. I know we've been chatting, but it's so nice to meet you or see you virtually. This has been so wonderful. And also thank you for sharing, an intro into the, Luxturna and gene therapy and this
Mhm.
idea of hope, because I really do believe it's, a new day for our community with everything that's available. So thank you so much.
Absolutely. Yeah, no, thank you guys for having me.
Yeah, and it looks like there's Riley just put it something in the chat. Best children's hospitals for Cohen kids experiencing continued CME.
I'm trying to think the best children's hospitals. I mean, there's lots of, it depends on what part of the world and what part of the country you live on. There's great people, great retina doctors everywhere. So, it kind of depends on where you are. And I put my email in the presentation too. So if there's any other questions that come up, you can feel free to email me.
Yeah, and if you, and I don't know if you could send us your presentation, or I don't know if it's
Yeah.
proprietary or not, or whatever you can send.
No,
that
I
way
mean, I'll
we
check with
can-
Dr. Bacall because some of the slides are his.
Right, it is.
But
But
yeah. That's
yeah,
all.
or at least love to add you as a resource
Yeah.
for, especially like Beth said, there's people up in that area.
Absolutely.
Did any other families have any questions, any more questions for Dr. Klein?
Mhm.
Well, Dr. Klein, thank you so much.
Oh, you're welcome. It's been a pleasure.
And
feel
feel free to stay on too, but I'm
Thank
sure,
you.
it's Saturday, but you're certainly welcome to stay on.
My husband's like fending off my toddlers right now. So
Oh, I know. So we totally understand. We